Hi, welcome to the Metastatic Renal Cell Carcinoma Tumor Board at Duke University. This is a interactive tumor board presented and sponsored by a grant from Pfizer and NCCN, and I'm your moderator and host, Dr. Dan George, a medical oncologist at Duke, and I'm joined here by my colleagues in radiology, medical oncology, and radiation oncology.
Thanks, Dan. I'm Rajan Gupta from the Duke University School of Medicine, Department of Radiology, and the director of the Abdominal Imaging Fellowship Program.
Hi, I'm Dr. Andrew Armstrong, an associate professor of medical oncology at Duke University.
Hi, I'm Grace Kim, and I'm an assistant professor in the Department of Radiation Oncology.
Great. Thanks, guys, for joining us, and I'm going to jump right in with the case if I can. This is a case of a 69-year-old woman who presented with gross hematuria back in June of 2011 and had a CT scan done in the emergency room that demonstrated a large mass in her left kidney that also had some enlarged lymph nodes in the left renal hilum and a 1 centimeter nodule in the lung. The patient underwent a left open nephrectomy and lymph node dissection, revealing an 8.1 centimeter grade 3 type 2 papillary renal cell carcinoma with lymphovascular invasion. So this was pathologic T2N2MX disease. And on the next slide here, I can show you some of the images. Dr. Gupta, want to walk us through this?
Sure. This is the CT scan that was performed originally out of the emergency department, and what we can see here is a very large mass that is involving the left kidney, heterogeneous with areas of necrosis centrally. One of the important things that from the radiology side that we want to look for from a staging perspective is to evaluate whether or not the renal vein is involved. And in multiple images here we can see the renal vein was not involved. In addition, we want to give perspective on lymphadenopathy, and there is a lymph node seen just to the left of the aorta that was approximately 1 centimeter in size. What's not imaged here is the 1 centimeter pulmonary nodule, but this was the lesion in question.
Okay. So after the surgery, the patient had repeat imaging done, and CT revealed new para-aortic adenopathy suspicious for progressive metastatic disease. A PET scan was ordered, and that revealed increasing lung and lymph node disease. And the patient was actually enrolled onto a phase 2 multi-center clinical trial called ASPEN, which randomized patients to either sunitinib or everolimus in the frontline setting. And Dr. Armstrong, do you want to comment about that study and about the use of these agents in the frontline setting and what we know about them?
Sure, thanks, Dan. Let me just start off talking about papillary kidney cancer. You know, when I think of kidney cancer, I think of many different diseases, both genetically and epidemiologically, that occur in the kidney that all fall under that term, clear cell being the most common. Of the non-clear cell kidney cancers, the next most common disease arising from the kidney is called papillary renal cell. And within papillary, we're learning that it's really composed of different genetic diseases under that histologic term. There's type 1 papillary, which tends to carry very good prognosis, rarely metastasizes, and is characterized by c-Met oncogene abnormalities, chromosome 7 copy gains. And really, this is a surgical disease or treated with ablation. Many of these cases can be hereditary, but they tend to be small, slow-growing tumors. Type 2 papillary is really a different genetic etiology altogether, and is really a much more aggressive disease. And there's really, of the non-type 1s, there tend to be different subclassifications. There's a recent report in the New England Journal subclassifying these tumors really into different prognostic categories based on genetics as well as epigenetic events that occur. P53, fumarate hydratase, CDKN2A. These are really distinct subgroups, and there's a methylator subgroup that really has the worst prognosis. These are all very challenging targets to attack, and many drugs that have been developed are really not addressing the genetic lesions that cause this disease. The ASPEN trial was designed actually over 3 to 5 years ago. It was a multi-center study. We actually conducted this from Duke. It involved 18 other sites around the world. Canada and the UK contributed. It was just published in the January edition of Lancet Oncology. This trial was a positive study in that we enrolled patients with metastatic papillary, chromophobe, and poorly differentiated or unclassified histologies. All had metastatic disease. Again, as Dan mentioned, they were randomized to sunitinib or everolimus, a VEGF versus an mTOR inhibitor, really standard of care dosing. But we really didn't know before this what the optimal systemic therapy was. Really, most of our data was based on case series, large registries, uncontrolled trials, case reports. And this was really the first and largest randomized trial. There was also another study done called the ESPN study, which had a very similar design. And both papers were published just in the last 2 months. In both of these studies, sunitinib came out a little bit on top. The progression-free survival determined by the time a patient has before the tumor progresses radiographically or before the patient passes away was superior in the sunitinib-treated patients at about 8 to 9 months, while everolimus provided a progression-free survival about 5 to 6 months. The response rates also favored sunitinib as well as overall survival. These drugs have differing toxicities, and there's a lot of heterogeneity actually in non-clear cell, where we saw greater benefits for other histologies with everolimus, such as chromophobe, which might be driven by more mTOR pathways. So in this patient with papillary, really the evidence clinically suggests that sunitinib as a VEGF tyrosine kinase inhibitor should be considered as the control group for future trials. It's really the optimal standardized trial option or off-protocol option for patients where a trial option is not available. However, the progression-free survival is relatively short. It's actually a little shorter than what you'd expect in clear cell disease, and it really emphasizes the fact that we need better therapies for this disease. And so that's what this trial really contributed to establishing a regimen as a standard of care option, but also a number of tissues were collected in this study to help answer the question of what's the best therapy in the future for patients like this.
Great summary. Appreciate that. So, so this patient was started actually as part of a study on sunitinib, 50 milligrams, 4 weeks on, 2 weeks off. And Raj, these are I guess the lymph node pictures now at this time, at the time of starting on study.
That's right.
Do you want to kind of walk us through what we see here?
Sure. What we can see here on the image on the top there is just that we have a periaortic, specifically retroperitoneal lymphadenopathy that we can see just to the left of the aorta. We can see that another lymph node more caudal to that as well, enhancing lymph nodes. And this is the original study that was done on 12/5/2011. There's a follow-up image actually that indicates size is one indicator of malignancy, but so is obviously FDG avidity. And this is the PET scan that was done that really shows the increased metabolic activity inside of that lymph node in the periaortic space. And in addition to the lymph node disease in the retroperitoneum, if we go one additional slide forward, please, you can see that there are pulmonary nodules as well, bilateral pulmonary nodules, both demonstrating increased FDG avidity. Really, the resolution of PET is at approximately 8 millimeters or higher. Mm-hmm. But we can see here nicely that these definitely demonstrate an increased FDG avidity.
Great. And do you want to comment a little bit on the vascularity of these nodes?
Sure. So this, typically when we image patients in the setting of renal cell carcinoma, we image them in the arterial phase and the portal venous phase, because we know that renal cell carcinoma is one of those tumor types that can have a hypervascular component. And these lymph nodes here really do demonstrate an increased vascularity when we take a look at that and are very brightly enhancing. And I think that's a great point.
Great. Yeah, so we traditionally think about clear cell carcinoma as being the tumor that's associated with that sort of hypervascular phenotype, yes. But clearly in this papillary case, this patient kind of shares that radiographic phenotype. And I'll mention why that may be significant in a minute. This patient went on sunitinib, as I said, on 50 milligrams, 4 weeks on, 2 weeks off regimen, but had a difficult time with this. Within that first 4-week period, she developed grade 3 thrombocytopenia, some grade 2 mucositis and hypertension, and had to hold drug. And interestingly, she was off drug for her 2-week period, which we stopped a little bit early, I think around day 23 or so. And when she came in to start on her next cycle, her platelet count was still low. It was 48,000, and her ANC had actually dropped down to 1,000. So we ended up having to hold for an extra 2 weeks before her platelet count recovered up to 157,000, and her ANC was over 1,000. And at that point, she was restarted on the drug, 37.5 milligrams, so a dose reduction, still 4 weeks on, 2 weeks off. Andy, what do you think about that dose reduction? And off study, are there any other modifications you consider in a patient like this?
Yeah, absolutely. So I think we're still learning a lot about how to dose some of these VEGF tyrosine kinase inhibitors, and especially that there's individualized dosing that can make a drug like this more tolerable for long-term use. The 37.5 milligram dose reduction is important, but I would also look at the timing of the toxicity. The thrombocytopenia in some patients develops right around week 3, and an early interruption, more frequent interruption, can prevent that just by doing a 2-on, 1-off schedule. So that's actually in the sunitinib label at this point. And in some studies, retrospective and prospective, that 2-in-1 schedule has been compared with the 4-2 schedule, showing improved tolerability. And improved tolerability may translate into improved efficacy long-term because of the lack of the need for dose holds and dose reductions. So that's something I would consider, particularly if this patient's experiencing early side effects.
Great. Of course, we didn't know that back in 2012, so that's why we kept this patient on the 4-2 regimen. And unfortunately, in cycle 2, she ran into a similar scenario where, again, she got into trouble before the end of her 4-week period. Her platelet count dropped down to 28,000. She presented with increasing weight loss, some grade 3 mucositis, and ANC down to 900, and some acute kidney injury with a creatinine up to 2.5. And she was admitted briefly for some hydration and support. Her sunitinib was held, and she was re-imaged then on May 7th, a couple weeks later, revealing evidence of some disease response here. And do we have these images?
We do.
Okay, let's take a look at those.
So this is the image from the same level in the retroperitoneum, the periaortic space, and what we can see here is that the amount of enhancement of that lesion, that lymph node, has certainly decreased, and also the size of the lymph node has decreased now to probably approximately 1 centimeter in short axis diameter.
So, so we held her sunitinib indefinitely at that point. We recognizing that she had this significant toxicity in a very short window of time on this drug, and had a response, had a significant weight loss, sort of clinical progressive symptoms associated with toxicity, but not with disease progression. So we held the drug and continued to follow her on study, and she continued to show evidence of disease control until December of that year, when a CT scan showed new and extensive hepatic metastases, some increase in progression of her retroperitoneal nodes. She had what appeared to be some thrombus within her left external iliac vein in the IVC, consistent with some tumor thrombus, and some lesions also within the spleen on arterial phase, also kind of suspicious. Raj, you want to walk us through what these look like?
Sure. So what we have here is some examples of imaging in the arterial phase. And in the arterial phase here of the liver, what we can see are multiple hypervascular liver lesions. And this is what is compatible with metastatic disease in the setting of renal cell carcinoma. In addition, what we can see on the bottom image is that retroperitoneal lymph node really has increased markedly in size just over a 5-month period. The hypervascularity is back, the increased enhancement is back, and now in addition to the retroperitoneal lymph nodes, what we could see along the posterior aspect of the image is a nephrectomy bed, or recurrence, as well as that soft tissue implant you described adjacent to the descending colon there.
And all of these share that kind of hypervascular phenotype that we saw earlier.
Absolutely.
When this first presented.
This is an example that shows specifically the tumor thrombus that you were referring to. So the major vein obviously is the IVC, and as we come to the common iliac veins there at the split, you can see there's some low density material as denoted by the lower yellow arrow that extends from the left common iliac vein into the IVC. We can differentiate between bland thrombus, or DVT, from tumor thrombus by assessing whether or not the thrombus enhances. And in this particular case here, you can see that this thrombus is enhancing. And then the upper arrow is really showing you that same retroperitoneal lymphadenopathy and that nephrectomy bed recurrence. You can see some of the surgical clips there as well, and it just shows you the extent of the disease process.
So let's go back to our case here. And Andy, could you comment on a couple of things here? This patient clearly has now fairly extensive progressive disease. developing now multiple sites of disease progression, including the liver, the local recurrence area, the retroperitoneum, and this sort of tumor thrombus developing into the IVC. What would you recommend for this patient next, and what other supportive care measures would you consider for her?
Sure. So first off, I wouldn't consider this patient VEGF TKI resistant or refractory. She actually progressed 9 months after stopping it for toxicity. And interestingly, there have been some studies linking toxicity with efficacy. Basically, some patients are slow metabolizers of sunitinib. They have higher drug levels. This may explain why her tumor shrunk and she responded. She may have had higher drug levels in her system and may explain her toxicity. Her tumor was VEGF TKI sensitive in that it responded when she was on it. And I would give strong consideration perhaps to an alternative VEGF TKI. She did respond to sunitinib but really didn't tolerate it even at a reduced dose. So I'd consider an alternative like pazopanib or axitinib as an alternative for this patient. However, she has a greater burden of disease right now with the thrombus, and I would consider this much like a DVT. She's at very high risk for pulmonary embolism and progression. She has active cancer. Her risk of further propagation of that clot is very high, and I would treat her with anticoagulation, either Lovenox or Lovenox bridging to Coumadin as far as supportive care.
And do you want to comment on PD-1 inhibition and papillary renal cell carcinoma? I know that wasn't available back in 2012, but now if this patient were presenting today with this kind of scenario, would this be a time to try that, or
yeah,
later?
I still think I'd probably try what's proven right now is a VEGF inhibitor, you know, knowing that she has responded to that before. We really have no data of PD-1 inhibition in papillary renal cell. We know that papillary tumors can express the PD-L1 ligand, but in the Checkmate study, actually, the expression of that ligand, at least in archival specimens, had no correlation with benefit. The label for nivolumab fortunately does encompass all renal cell carcinoma patients, so you can use this on label. But really it would be most appropriate for a patient who's failed a VEGF TKI. And while she's progressed, I still think there may be some benefit gleaned from another trial of a VEGF tyrosine kinase inhibitor. It wouldn't be wrong to use nivolumab, but we just don't have much clinical efficacy data, although there are trials investigating that question right now in papillary and other non-clear cell subtypes.
Great, great. Well, it was easy for us back in 2012. There weren't a lot of other options. We did go with the axitinib, and we started her at 5 milligrams BID. She had recovered off of the sunitinib, all those side effects that she had experienced, and we did prophylax her with warfarin as well. She did develop toxicity within a couple of weeks on this, including hypertension and fatigue. But her platelet count, interestingly, remained normal. We started her on lisinopril for her hypertension, but shortly thereafter, her hypertension really escalated out of control, got up into the diastolics of 120s with some headache, and her axitinib was held. She was admitted to the hospital. Her lisinopril was escalated up, and her blood pressure was controlled with some short-term hypertensives, and her Inlyta was restarted with her blood pressure back down into the normal range at 3 milligrams BID. And on this dose, she again was able to tolerate this, although did develop again grade 2 hypertension, fatigue, and constipation. So even with a dose reduction, this is a patient that had elevations of blood pressure associated with axitinib. Any comment, Andy, on that degree of hypertension in this patient?
Yeah, Inlyta or axitinib is another one of those agents where there's wide variability in the amount of drug patients actually are exposed to individually, and you can see again high levels of drug levels in some patients, and that may correlate with response and toxicity. And so she may be a patient who just has a different liver metabolic machinery and has very high drug levels, and maybe that a very low dose is what she needs to balance that quality of life toxicity with her efficacy. She's clearly responding, so I think you made the right choice in systemic therapy. I would probably keep her on it, but another point is that axitinib is dosed continuously, but we don't really know what the value is for alternative schedules such as planned breaks, and would consider that in a patient like this. Individually, probably a lower dose, maybe 2 milligrams would get her through it, or perhaps brief breaks to interrupt it, along with antihypertensives.
Great. Yeah, so this is a common challenge for us in the field, is patients balancing that toxicity profile, quality of life with efficacy. Regarding efficacy, she, as you saw before, had a lot of extensive progressive disease and showed evidence of response in that. Raj, you want to walk us through those before and afters?
And what we can see here is that there are certainly still hyperenhancing lesions seen throughout the liver on the arterial phase of imaging, but the lesions are smaller. This was a significant decrease some decrease in size here. If you go one slide further, please. We can see here really a much more impressive improvement in the lymphadenopathy seen in the periaortic space, as well as in that soft tissue mass that we saw adjacent to the descending colon, almost gone to nothing on the 325/2013 scan, and that really impressive reduction in size of the soft tissue mass in the posterior aspect of the image there.
Great, fantastic. So really fortunate to see that kind of response, especially given the extent of disease that she had. We restarted her in LIDA and dose reduced her down to 2 milligrams twice a day. And she tolerated that much better and had some left leg swelling along the way, evident of some progression of DVT on her warfarin, so we switched her over to enoxaparin. And she continued with evidence of disease response, either slight decreases or stable disease in notably the liver and nodal disease over about a year period of time, a little over a year's period of time on this agent. Andy, what do you think about that duration of response?
I think it's excellent. I think with papillary renal cell, as I mentioned in our clinical trials, the progression-free survival median is about 8 months. There are some outliers, and obviously we need to understand biologically who really has an outstanding response. She has, but now at this point she's progressing on this agent pretty much at the max dose that she can tolerate, and I'd consider her VEGF refractory at this point.
Yeah, so in February of 2015 she developed evidence of progressive disease with some new mediastinal nodes and importantly some symptomatic progression now with some pain in her nephrectomy bed. And Raj, want to walk us through those?
Sure. So this is the scan actually that was done during one of the periods of time that you discussed prior to February, and you can really see impressive improvement. This is an arterial phase image on the top, and really almost complete disappearance of all of the liver lesions. The same things that we were able to see in the periaortic space are again there. We don't see any substantial lymphadenopathy, and that soft tissue mass along the posterior aspect of the abdomen adjacent to the descending colon was pretty much gone. If you go one image further, we can see how things have changed as we get to February of 2015. Really extensive lymphadenopathy throughout the upper mediastinum, adjacent to the aorta as well. On the bottom image, we can see new nephrectomy bed recurrence with that same almost hypervascular or hyperenhancing areas posterior and adjacent to the psoas muscle, so worsening disease.
Right. Okay, so this patient went on to get palliative radiation therapy to the left nephrectomy bed. Grace, do you want to comment on the role for radiation therapy as a palliative agent for renal cell carcinoma? Historically, some people think of renal cell carcinoma as being kind of radiation resistant.
It is, if you compare renal cell carcinoma with histologies like breast or prostate, it can be not as responsive as those histologies, but it still does respond to a degree. And so radiation, I would say, would be effective, but sometimes we dose escalate. Maybe we add another fraction to try to exert some more local control. With this lady, I think that radiation is indicated in her case because she's got a focal spot of pain, and in particular this is in the back, and so we can use radiation to aim that area with very little symptoms. Nausea, diarrhea sometimes can be complications of radiation to the abdominal cavity, but if we add more beams and also in this location towards the back, I would expect her to do very well.
And what do you think of the course of 5 fractions? Is that typical? Is there a range? And how do you decide on how to divide that up?
So depending on the performance status, depending on the number of sites, depending on if she needs to get to chemotherapy quickly, we would go anywhere from 1 treatment, so 8 gray times 1, gray being the unit of radiation, like pounds is for weight, anywhere up to 15 fractions if we want to exert some durable response. And so if we want to get her to chemotherapy quickly, then I think 5 is a great number of treatments, because that's just a week off of treatment. And so 5 also has been shown to be equivalent to 10. It's but more durable than 1.
Great. So that's what we got in exactly right. This was a patient that we were concerned about symptoms. She went on to with progressive weight loss, increasing pain despite the radiation, nausea, vomiting, and was started on everolimus 10 milligrams daily. Andy, do you want to comment on everolimus for papillary renal cell carcinoma?
Sure. So if you look at the genomic sequencing data from the TCGA, there are pathway mutations in the PI3 kinase mTOR pathway in papillary renal cell, but it's a small fraction. There's probably 5 or 10% who have those mutations. So that's probably why it's not as effective as a more broadly acting agent like sunitinib. But I would offer it. You know, in our trial, there was a progression-free survival rate. There were responses. It tends to be short-lived, 5 to 6 months rather than 8 to 12 months. But some patients can respond. It has different toxicities, obviously mTOR-based toxicities, lipid problems, pneumonitis, immune suppression. So patients need to be counseled on those. I'd probably give it a shot if she's still willing and able and has a good functional status to try this. I'd also look for clinical trials, maybe phase 1, given that we have a low expectation for systemic therapies at this point.
Yeah. With a poor performance status and weight loss and nausea and vomiting, she really wasn't a phase 1 candidate. We tried this mostly for palliative purposes to see if this could help, and actually kind of backfired. Whether it was the drug or whether it was the disease or a combination, she quickly developed acute renal failure and ended up with in the hospital with a creatinine of 10. She was on dialysis for about a week or so, and then the decision was made to discharge home with hospice, and she passed away with hospice at home about 3.5 years from her diagnosis. Is that a typical course for somebody with papillary type 2 cancer? And now, are there newer things that you would look for the next patient that comes into our clinic with this type of scenario?
Sure. So the median survival in the trials that I talked about, ASPEN, ESPN, was about 3 years. So patients can often get second and third line therapies for this disease. The problem is that many of the second and third line therapies are ineffective. So we are searching through the genetic database for targetable, actionable mutations. Some of those from the large data sets indicate perhaps epigenetic events are important in this tumor type, so perhaps epigenetic regulators may be helpful. Mutations, again, in the PI3 kinase pathway, the c-MET oncogene, cabozantinib, which can target that, has shown some activity in this disease. Not yet approved for kidney cancer, however, although possibly under review soon. But there's a number of investigational approaches that are cell cycle inhibitors, metabolic pathway inhibitors, EGFR inhibitors being combined with VEGF inhibitors such as bev or erlotinib has some activity in this disease. Really, it's enrollment on a trial with the hope that we can pair precision medicine with some of these systemic therapies. So there's hope on the horizon, but I think we need to enroll patients on trials at this point.
Great. Well, and with that, I think we'll end our tumor board. Thank you very much for your attention.